السلام ورحمة الله وبركاته. Okay, I will start with you this group of images. Patient
Uh,
has pain and swelling.
okay, this is MRI of the elbow. Um, uh, this is showing that there is significant, there is evidence of a hyperintense lesion noted at posterior aspect of the elbow
Good.
in subcutaneous location. I cannot see any bony erosion associated with it.
Very good.
However, there is mild joint effusion noted.
Okay.
So it is some
Magic F.
benign. It is some benign etiology, but I would like to correlate with the patient's clinical history. If there is any history of
Trauma, for
uh,
example.
yeah, trauma, it can be hematoma. If there is
Yes, good.
any history of injection, less likely it can be soft tissue edema. If there is any history of infection or sepsis, it can be inflammatory collection like abscess. And I would also like to review the patient's history notes for further to reach out diagnosis of the patient.
Okay. You
And
mentioned many differential diagnoses, but the correct one is not yet.
sir,
Okay.
it can be some
Anatomy. Anatomy.
subcutaneous.
No,
Uh,
no, anatomy. What is the
okay, sir,
location of this?
it's adjacent to olecranon. So one
Yes.
differential is the tophicaceous gout. It
Yes.
can be yes, sir, it can be deposition of the crystals of the gout in this
Very
position,
good.
and it's
Very good. Very good. Idiopathic, non-traumatic polycranon bursitis equals
okay.
gouty until proven
PRT.
otherwise.
Okay.
Idiopathic, non-traumatic pre-patellar bursitis, you should suspect gout until proved otherwise.
Otherwise.
Polycranon and pre-patellar.
Okay. This is
Pain, 70
okay.
years.
70 years. Okay, this is X-ray left elbow, in which lateral projection, in which I can see that there is evidence of multiple lytic lesions noted in medullary cavity of humerus as well as radius. However, I cannot see any, and there is evidence of there is a suspicion of cortical breach in the proximal radius or radial proximal metadiaphysis, with some periosteal reaction and soft tissue swelling also. However, ulna appears to be spared. The joint is also normal. There is no other area of cortical breach. So if the patient is 70 years old and he has a history of pain, I would like to keep the differential of multiple myeloma at the top. Then second would be metastatic mets from any primary, for which I would like to know about the history of the patient and review the clinical notes, and will also I will want to see the previous images if
Good.
available for comparison. And
If
further, I
you are
would
suspecting multiple myeloma, what is the next
MRI
step?
or low dose whole body CT.
صح. Yes, yes, both correct. And of course, full
Full
CBC
body.
and
Yes, sir.
serum and urine electrophoresis. Very good. Another case, yeah, boss.
Okay, this is basically extra chest frontal projection of a skeletally mature patient, and the first striking abnormality in this, I can see that there is an area of sclerosis arc and ring-like sclerosis noted involving the right humeral head, um, with the preservation of the joint space. And on the right and on the left side, I can see that the humeral head is mildly displaced inferiorly.
Subluxed. Very good. Mild. And by the way, NB for practice, if the humeral head is displaced inferiorly only or inferolateral, there is effusion. It is not
Okay,
dislocation.
okay,
Maybe
sir.
inflammatory effusion like rheumatoid arthritis or post-traumatic, no problem. Okay?
Okay, sir. Okay, sir.
Dislocation infromedial, not
Inframediate,
infrolateral. Okay? So
lateral.
this is some subluxation, likely by effusion. Very good.
Oh, okay, sir. Okay, sir. Coming back towards the right arm, I will like to keep the differential of some chondrite lesions. It can be some
Hmm?
first is chondrite lesion, second can be metastatic deposit, um, and
Metastasis like this?
uh, no, sir,
Unlikely.
it can. So these are
Unlikely,
basically
unlikely.
okay,
They
sir.
they are
Chondrite
they
lesion.
they are deceiving you by the breast shadow. Okay.
No, sir, I haven't seen this. So it's more, I would like to keep the two differentials in this. The first will be enchondroma, second
Yes.
can be bone infarct, but the position and location of the lesion points towards enchondroma like
Okay. If I told you 50 years old, we have to put another differential, low-grade
chondrosarcoma.
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 Low-grade chondrosarcoma cannot be
Okay, sir.
differentiated from enchondroma. So you
Okay, sir.
need to rule out any aggressive criteria, intact cortex, no
Okay.
periosteal reaction, no
Mm.
exaggerated lucency, no deep endostal scalloping. However, in my routine practice, I would proceed further to MRI. And this is the first step. All friends, please concentrate. This is the first step. Comment on breast shadows. It's very, very, very common exam case. Mastectomy
Okay.
with some metastasis anywhere. Okay. Last case, nuclear. Easy.
Okay, this is a nuclear scan of an adult patient, anterior and posterior projections, in which I can there is reduced tracer uptake in both kidneys. However, there is significant tracer uptake involving the skull, left femur, tibia, and right iliac bones, and the left humerus as well. And the bones are also expanded uh,
Excellent.
in in anatomy. So expansile lesion involving multiple bones. The first differential in adult patient is Paget's disease. Second would be less likely some metastatic deposits, but I would like to correlate with the history of the patient and would review the clinical notes, and will see that as there is suspicion of a lytic or as a region of decreased uptake in the iliac blade, I would also like to review MRI of the patient, or if it's not done, I would recommend MRI of the patient,
Very good.
as there
Very
is
good.
increased propensity
In younger age group, this may
if
mimic the fibrous dysplasia, by the
fibrous
way.
dysplasia. Okay,
Any
sir.
specific laboratory test?
Um, for Paget's,
No one help, please. Okay.
alkaline phosphatase. Sir, alkaline
Excellent.
phosphatase.
Excellent. Very good. Very good, يا boss. Okay. Thank you, يا boss. Thank you.
Thank you, sir.
Okay, the
Okay,
next candidate.
candidate number 7, please unmute yourself.
Assalamu alaikum, sir.
عليكم السلام ورحمة الله وبركاته. The last laboratory test is alkaline phosphatase. Alkaline phosphatase increased significantly in Paget disease. Okay, boss, you can start. This patient has pain and 9 years old.
This is a lateral ankle projection of a pediatric age group patient, in which I can appreciate that in the body of calcaneum and in its anterior process, there is a very well defined extensile lesion with internal septations. There is a narrow zone of transition, no overlying periosteal reaction, and there is no internal chondroid calcification. There is no bone break. However, I would like to see it on the other view as well to confirm it. The underlying soft tissue is swollen, so the heel fat pad is swollen. It could be reactionary due to overlying inflammation. My differentials based on this is that it could be ABC or it could be simple bone cyst.
What is
Um,
ABC? No abbreviations in the exam. Remember, huh?
sorry,
Aneurysmal bone
sorry, sir.
cyst. Okay, no problem. Don't apologize, يا boss. Okay, so aneurysmal bone cyst versus
Versus versus simple bone cyst,
good. Simple bone cyst
intraosseous.
actually will be number one. Simple bone
Okay,
cyst, aneurysmal bone cyst, or This lesion. What is the difference between this lesion and the first one?
Sir, this lesion is showing an internal calcific foci, which is
Very
very
good.
significant of Crockett sign, which is seen in the intraosseous lipoma, and
Intraosseous
it is
lipoma, and it
also
is called Cockade sign. Good.
Crockett sign.
Okay, and this is the equivalent CT. So just to revise, my friends, there is an area in the calcaneus which may show defective trabeculation. This is normal. It's called pseudo lesion or pseudocyst. If it is if it is well defined, then it's a lesion. The commonest one here, simple bone cyst. The second common, lipoma. Lipoma may be like simple bone cyst or very characteristic central calcification, Cockade sign. Okay. What about this case? Pain.
This is the lateral foot radiograph of an adult patient showing a lucent area within the calcanea with surrounding sclerosis, and lesion is ill-defined. There is a wide zone of transition. However, I can also appreciate that there is some periosteal reaction on all the sides surrounding it. The surrounding bones show some diffuse osteopenia. There is, however, no fracture line seen, which I would like to confirm on any other view. Uh, I would like to take the history. If there is history of fever, it could be an
Good.
infectious focus. There's a
Like
central
Brodys abscess, like Brodys abscess. Very good differential. What else if the patient is 20 years?
Sir, there is a central, I can appreciate maybe its projection. There is a central density surrounding with the lucency. Then this picture can also suggest some osteoid osteoma, although that is not that much big. Osteochondroma or osteoblastoma can be a differential osteoblastoma.
Okay. If a well-defined lesion within the calcaneus, you mentioned before bone cyst or lipoma in young age, Brodys abscess accepted. Chondroblastoma is accepted also because all tarsal bones considered apophysis or equivalent to epiphysis. Okay? If associated with significant sclerosis, two or three conditions can be associated with extensive sclerosis. Osteoid osteoma, but very small and cortical based. Chondroblastoma, yes, and even osteosarcoma. Okay, what to do next?
So next I would do MRI with contrast of the patient.
Okay, MRI revealed.
Sir, in MRI, the lesion is well defined. It is hyperintense.
Good.
And there is a strong reactionary changes in the surrounding soft tissues.
Yes, and internal.
And internal hypointensities are also seen.
The lesion is hyperintense, very hyperintense, with low signal intensity. This is rings and arcs. Is chondroid.
Can it be low? Yes, low-grade chondrosarcoma.
No, 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 no. It's chondroblastoma, chondroblastoma. Chondroblastoma. Okay. Chondroid matrix can be seen in chondroma, correct. But if well-defined, it's a chondroblastoma. And this is considered epiphysis, equivalent to epiphysis. So chondroblastoma. Significant edema, significant sclerosis, and even soft tissue edema with effusion in the joint. It's chondroblastoma with chondroid matrix. Okay. Leave this case to the next one and give me, vein.
This is the lateral wrist radiograph, in which I can appreciate that there is a periostitis, a periosteal reaction, and there are shaggy boundaries of the radius seen. Actually, it is also the same finding the seen in ulna as well. It is looking like periostitis. The intrinsic bone, there is no intrinsic bone derangements, and the there is a radius carpal and scaphoid are in line. I would like to see the frontal projection of this patient just to
Yes,
rule out that this is.
I'm waiting يا boss. Okay.
So this
My
look
routine
like
practice, I should comment on the other orthogonal view. Okay. What's now and what's the next?
sir, it is a florid periosteal reaction which is bony. And I would like to know the age of the patient, any associated lung history, or if the patient is not a known case, any recent chest related
Yes.
symptoms.
Yes, this is a
If the
classic
patient
hypertrophic osteoarthropathy, and the patient has already some lung disease, maybe fibrotic lung disease. Okay, what about this case also? Pain.
So this is a lateral hand radiograph specific for some fingers. I don't know the name, which is showing that there is expansion in the. I think this is
Excellent.
especially for the thumb to make out the clear boundaries of it. It's a metacarpal bone, and it is showing this an expansion. There is widening of the medullary cavity, overlying bony thinning. The trabeculae are thin but becoming prominent, and the remaining bones are showing normal. Some changes are seen in the adjacent proximal phalanx, but this appearance, if it is diffuse in all the bones, I can think of thalassemia, but this can be of
Excellent.
enchondroma. I would like to see any other view available
Very
just to
good.
rule out
Very,
that is
very,
this
very good.
finding.
Very good. Yes. Usually, my friends, we have waist. In the metacarpal bones, we have waist. Reduce the caliber in the central part. And usually, we have a very thick cortex in the metacarpals. If we measure both cortices, it will equal to the medullary cavity. Unlike this case, the waist is lost. The waist of the bone is lost, broadening of the medullary cavity, and the cortex become very thin with trabecular prominence. Very good, yeah, boss. It's a case of thalassemia. And if agree, if unifocal, it may be a case of enchondroma. What about these patients?
So these are
Adolescent.
early and delayed phase of frontal and posterior views of bone scan, in which I can appreciate that there is abnormal uptake in the proximal fibular region, with a central area of low uptake, and it appears very well defined. Um, there is some uptake in the other fibula as well, but that is most likely the epiphysis. I can appreciate both normal renal uptake, bladder uptake,
Good.
epiphysis are
Is
normal.
the first
I
step.
would
Yes. Very good.
the epiphyseal region uptake is showing that it is likely a pediatric age group,
Is
and
normal.
this no.
Normal يعني normal physis uptake. This is immature skeleton. So when you present this case, MDB or full body bone scan in skeletally immature patient where all physes are taking uptake. I see the renal uptake, it's not super scan. Then I'll see an area in the left, I'm sorry, right fibula surround area of uptake, surrounding area of, or photopenic area in the
Hmm.
epiphysis. This is a sign named
It is sign name double density sign, osteoid
mm,
osteoma, donut sign.
double density if the density in very high inside more than the periphery, higher in the center rather than the periphery. But here, higher in the periphery rather than the center. It's the reverse of double density. It's called donut sign.
Hmm.
It means empty center. Donut sign may be seen in case of simple bone cyst, aneurysmal bone cyst, or an older age group, giant cell tumor. So this lesion may be epimetaphyseal, either simple bone cyst or aneurysmal bone cyst. Okay,
Hmm.
it's
Okay,
called
sir.
donut sign. I don't know if there is double dynasty. No, no problem. Okay. Thank you, يا boss. Thank you.
Thank you so much, sir.
Welcome. Okay, the last candidate, so we
Yes,
can
sir.
take
Last, we have candidate number 8. Candidate number 8, are you with
Yes,
us?
yes, yes. Assalamu
Okay.
alaikum.
عليكم السلام ورحمة الله وبركاته. يلا start with easy case. This
Okay.
patient 20 years.
This is the X-ray distal tibia fibula of a 20-year-old male. I can see that there is a dense sclerotic lesion involving the distal shaft and the metaphysis of the fibula with florid sclerotic with florid periosteal reaction giving a sun ray appearance
Very
with the
good.
marked overlying soft tissue swelling. There is a wide zone of transition.
Good.
Because of this osteoid type of periosteal reaction, the most likely diagnosis here is the osteosarcoma.
Good.
I would further advise for the MRI of the patient, and also will
MRI of
MRI of the leg, and I will advise for the
whole bone should
CT.
be imaged. Why?
All bone should be imaged, including the joint above and below,
Why?
to see other lesions in the bones.
Skip lesions.
Skip lesions.
Buzzword here. There is
Skip lesions.
buzzwords. The examiner want to hear it. Okay. Skip
Okay.
lesions. Okay. Number 2, what you will do next?
Next, metastatic workup.
Very good. CT cab or CT
Yes,
tab.
yes.
By the way, cab means chest, abdomen, and
Abdominal
pelvis.
pelvis. Yes,
Tab
yes.
also abdomen and pelvis. Okay.
Yes. And
And
bone scan,
very good. Bone scan. And last step,
biopsy.
biopsy at.
Uh,
If you said
biop
biopsy only, you will lose marks.
okay, okay.
Biopsy at.
Um, Biopsy, histopathology,
Okay, I know histopathology and biopsy is the same.
biopsy, yes.
Okay, at the
Biopsy.
radiology department, for example.
No,
Bi-
I will refer the case to the sarcoma MDT for further
Yes,
management.
yes, yes.
Yes.
So
Okay.
biopsy at specialized sarcoma
Sarcoma center.
center.
Sure.
Specialized bone sarcoma center.
Bone sarcoma center,
Very
yes.
important because the biopsy tract, okay, will be planned to be removed during surgery. This is
Right.
very important, okay? During
Yes.
Viva and also in short reporting. My friends, if you will diagnose osteosarcoma, Ewing sarcoma, please discussion at bone sarcoma MDT and biopsy at special sarcoma center. Okay. No, this is osteosarcoma. It's a classic osteosarcoma. If you want to differential, Ewing, but less likely. Okay. Pain.
This is the X-ray distal fibula of a skeletally mature patient. I can see some well-defined sclerotic lesions within
Good.
the metadiaphysis of the right distal tibia.
Very
On
good.
the lateral aspect, there is no periosteal reaction. There is no cortical break, no overlying soft tissue swelling. These appear to be benign lesions.
Like what?
These are not lucent.
No one answer, please. Okay, no one answer. Like what? I want here to do the mistake alone. Okay. Like what? Like Bone Islands, for example.
Bone Island, yes, yes.
Okay,
Okay.
correct.
Benign finding, Bone Island, yes.
Okay, very wrong answer. Why? In my routine practice, I will comment on one view.
No. I would like to see the lateral view of the patient.
Yes.
Okay.
I
So
think
these
you
are not
you
in the bone.
it's
These are
it's a
located in
good,
the
it's very
soft
good
tissue.
you
Yes,
did the
yes, yes.
mistake. I'm happy, by the way. If you did the mistake with me, inshallah, you will never forget it. Okay?
Yes, yes.
Any radiograph of the skeletal system, please, my friends, mention to the examiner in my routine before you give the diagnosis. Before you give a diagnosis, mention to the examiner in my routine practice. I will comment on other orthogonal views before giving the final diagnosis. If he
Yes.
said يعني no additional data in the other review, okay, give the final diagnosis. So here, I let you complete the case, but how to describe this? Multiple sclerotic small lesions are seen projected over,
Right.
not within, not within distal tibia. No, projected over distal right tibia, which may be bony or osseous in origin, may be soft tissues and overlapped on over the tibia. So I'd like to see other view. Now continue.
Okay, there are multiple well-defined sclerotic lesions which are noted in the soft tissue posterior to the distal tibia and fibula with distant soft tissue swelling. Um, Most likely diagnosis here is soft tissue hemangioma
Very good.
with multiple calcific foci.
Yes. And this is
I
a
would
MRI of the
confirm
same
these
patient.
findings on further MRI.
Yes. يعني no need خلاص يعني multiple low signal intensity. This is a Philippine. Okay, I'll give you another case. This is a simple case. It's
Yes, I will describe. This is the X-ray knee joint lateral view of a skeletally immature patient. I can see a well-defined lytic lesion with surrounding sclerotic margins and narrow zone of transition in the distal diaphysis of the in the diaphysis of the distal femur. There is no cortical break, no overlying periosteal reaction, and no other bony lesion seen. The knee joint appears space appears unremarkable. Before giving my diagnosis, I would like to see the orthogonal view.
what if I told you the patient has a multiple similar lesions?
Yes, then this is most likely a cortical, one second,
Fibrous cortical defect.
fibrous
Okay.
cortical defect, and
This is
then
stress
it will
factor.
be
Okay. In multiple
multi.
fibrous cortical defect or multiple non-ossifying fibroma. Any syndrome?
Yes, it is called Jeffrey-Campanecki syndrome.
Excellent, excellent. Any skin manifestations?
Skin manifestations, if it is associated with the if it is associated with hemangi sorry,
Cafe au lait.
hemangiomas.
Cafe au lait.
No,
Okay.
no, no. So it's soft tissue sarcomas.
I think a cafe au lait. Skin
Oh,
pigmentation. Okay.
okay, okay, okay.
Okay. What about this lesion pain?
Okay, this is the X-ray knee joint frontal projection of a skeletally immature patient. I can see a well-defined lucent lesion with surrounding sclerosis that is seen in the epiphysis of the distal femur. A few internal hyperdense foci are noted. There is the lesion is also noted. The similar lesion is also noted involving the distal metaphysis of the femur.
Mm, so,
This
it's a
this
single
is
lesion, I
single
think.
lesion. Okay,
Okay. Meta-epiphyseal.
a metaepiphyseal.
Okay. With a sclerotic margin. In
Yes.
my routine practice, of course, I will see
Yes, I
the
will see
other
the lateral
orthogonal.
view. Yes.
Okay. The orthogonal in the knee, by the way, is helpful in rule out any effusion,
Right.
suprapatellar and infrapatellar. Okay.
There,
So
there is
every
fullness of the fat pad suggesting mild effusion.
okay, yes, mild
Yes.
diffusion is here. Very good. Meta-epiphyseal lesion in a skeletally immature individual.
Yes, my first diagnosis is osteomyelitis.
Very good. Very,
Yes.
very good. Another
Yes.
differential?
Another differential, if it is involving only the epiphysis, then it can be chondroblastoma.
Yes. Uh, Osteomyelitis starts or produces abscess in the metaphysis, may
Yes.
extend in the epiphysis.
Epiphysis, yes.
Chondroblastoma start in the epiphysis, may extend
Yes.
into the metaphysis. So
Right.
two good differential diagnosis. I need
Yes.
to what to do next?
MRI.
MRI in T. You tell me بقى. I will give you the contrast directly so I can give you another case. هنا post contrast.
Yes. There is a heterogeneously a hyperintense peripherally enhancing lesion noted
Yes.
in the
This
metadiaphysis of the distal femur, which confirms the finding of Brody's abscess.
yes.
There is
Urgent.
yes,
Urgent.
this is urgent referral to the pediatric orthopedic for further management.
Okay. Pain 45 years.
This is the X-ray the knee joint of a 45-year-old patient, in which there is eccentrically located lytic lesion involving the distal femur. On the lateral aspect, it is involving the metaphysis as well as reaching the epiphysis. There appears to be a subtle cortical irregularity on the lateral aspect. The lesion appears to be having wide zone of transition.
Wide?
Uh, mm, no, narrow zone of transition, sorry.
Are you sure? Wide or narrow? You
My
have to
first
be sure.
impression was
You have to be sure. Okay.
my first impression was like it's not very benign looking.
Benign looking, correct?
Uh, but there is no overlying soft tissue swelling. There is no periosteal
Good.
reaction.
The fat here is preserved.
Preserved, yes,
So
yes.
definitely
I
no
would
soft
like to see it in
tissues.
the orthogonal view.
Yes, good, good. This is the orthogonal view. Relatively defined or fairly
Yes,
defined. Okay.
well defined, and involving the it could be
Huh? I'm waiting for the
an
mistake.
an
Lesion reaching the epiphysis in an
epiphysis, yes.
adult
Adult
patient.
patient. The most likely finding the diagnosis, it could be a giant cell tumor.
Very good. What is the differential? Correct, correct, by the way.
Differential could be aneurysmal bone cyst, but that would be seen in the relatively
Younger
immature
age
skeleton.
group. Okay, younger age group.
Younger
Any
age
other
group, yeah.
differential?
Any as it is a non-aggressive lesion, so
No problem. Malignant lesions may be non-aggressive.
yes. So other possibility could be metastatic deposits.
From where? Brown tumor is
From
accepted also. Yes.
yes, okay.
From where?
As this is a lytic lesion, so it could be from the lung mets.
No, lytic
From the
and the expansile.
okay.
This will narrow the differential.
Right.
Lytic expansile. From where? Two main.
Thyroid, renal cell.
Yes. Very good. It was
Yes.
renal cell carcinoma metastasis, not
Okay.
giant cell tumor. Very good, Yabos. Very, very good. Not bronchogenic, by the way.
Okay.
Expansile, lytic, renal, and metastasis. And renal and thyroid. Okay. I'll give you, yes, this case. Pain.
This is a bone scan image of the pelvis. I can
Yes,
see
left hip pain. Okay.
left hip pain. Okay, I can see a focus of increased tracer uptake in the neck of left femur, or I can say in the lesser trochanter of femur.
Good, very
On
good.
the left side, I would like to know about the patient's history as well as the age of the patient. If it is an old age patient, it could be some metastatic, like it could be a pathological fracture. If it is young patient, then it could be due to some tendon injury leading to the fracture of the lesser trochanter.
Or just medial femoral,
Okay.
like stress fracture. Very good,
Yes,
yes.
stress fracture.
So
Yes.
it may be this is another patient, by the way. Maybe something like this, which is pathological fracture, as you compare. Lesser
Yes.
trochanter fracture in adult is pathological. Or
Yes.
maybe this is another patient, maybe osteoid osteoma, but osteoid osteoma has a classic, yes. This is the double density.
Yes.
Okay? Increase the
In the
inside
increased
more
density in
than
the
the
middle.
perimeter.
Yes.
Yes.
Okay.
And also maybe, yes, something like this. Stress fracture. All these lesions cause area of uptake at medial aspect of the femur or proximal or lesser trochanter. This was a stress fracture.
Right.
Thank you, boss. Thank you. Thank you, all my
Thank you.
friends.
Thank you so much.